Our next paper will be 2-year results in 40 patients with the Venovalve for deep venous insufficiency.
Good morning. I'm Matt Smeds. I'll be talking about the 2-year results in the first 40 patients with the Venovalve in the SAVI trial. These are my disclosures. I was the site PI for the InVeno SAVI study. InVeno has also provided grant support for our lightly embalmed cadaver course, which we hold every fall. So if you have a resident or trainee who wants to go, let me know. It's a good course. So chronic venous insufficiency, as I'm sure you all know, is an important problem for many patients. Millions of patients are affected on a yearly basis in the United States. It causes significant issues with direct medical costs and wound care for patients. These people often have ulcers that are recurrent. They end up missing work days, and so it's a big problem. The treatment for CVI has classically been compression, which is not really well tolerated by many patients. It doesn't cure the underlying disease. It does work, but you get recurrent disease, and it's just a cycle of compression, failing compression, and restarting compression. There have been a number of deep venous valvular reconstruction surgery options presented over the years. These are limited to a few centers worldwide. There's inconsistent techniques, and there's really no standard prosthetic valve that has been used up to date. The Venovalve is a glutaraldehyde cross-linked monocusped porcine aortic valve leaflet with a section of aorta in a rigid stainless steel frame. It comes in 2 diameters, 9 or 10 millimeters, and is 21 millimeters in length. There is a 3 millimeter sinus protrusion you can see on that bottom picture, which acts as a flow regulator, which reduces stress on the leaflets and results in a little bit more laminar flow through the device. And the role of these sinuses in prosthetic venous valves has been demonstrated. The device received FDA breakthrough device designation after the first in-human study was done. This showed in 11 patients the Venovalve appeared to be fairly safe now up to 3 years, with a 63% average improvement in reflux, a 64% average improvement in the RVCSS score, 83% improvement in a pain score, about an 80% of primary patency rate. Most of these patients were continued on anticoagulation. This led to the pivotal SAVI study in the United States. This was a prospective, non-blinded, single-arm, multi-center pivotal study. Its objective was to assess the safety and efficacy of the Venovalve for the treatment of patients with deep venous valvular insufficiency. This was 75 patients at 24 U.S. sites. The main inclusion criteria was the patient had to be C4B, which is lipodermatosclerosis or higher. So these people oftentimes had ulcers or healed ulcers. These were the basic demographics for the entire cohort. You can see that the average age is around 63. They were mostly men, mostly white, and most of them were obese. If you look at their SEEP classification, 58% were C6 SEEP, so they had ulcers. And of these, 70% had had their ulcers for more than a year. So these were people who had chronic ulcers for long periods of time. Patients were followed at 1, 3, 6, and 12 months, and then yearly device patency, RVCSS, and some quality of life scores, as well as a pain score, and then ulcer healing was monitored. Ulcer healing used the Swift app, which looks at the ulcer size using an iPad. Unfortunately, we do not have this data on the 2-year and the first 40 patients that I'm presenting today. The 1-year outcomes were presented recently at the VEITH meeting. This showed primary patency of around 87% with a secondary patency of 97%. Interestingly, the device patency overall was 98.4%. 9 patients actually occluded their device within the first year, but 8 of them recanalized, many of them with decreased reflux below the device, and many of them with ulcers that subsequently healed. There's no procedural related or valve related mortality in the study period, although 1 patient did die from COVID related issues, and there were no device related infections. So the goal for today is to report on 2-year outcomes in the first 40 patients who have made it that far. These are the demographics of those patients who have made it this far, 2 years into the SAVI study. Similar to the overall demographics for the group, again, average age around 63, mostly men, mostly white, mostly obese, and again, mostly people with advanced ulcer disease. In this set, there's around 52% who have C6 disease. And then of those, 61% of these had had their ulcers for more than a year. We have 27 patients of this group have core lab data available for analysis. All these show patent devices at 2 years. If you look at the RVCSS score, This improved dramatically at 3 months and is kind of stabilized at that point, which you would kind of expect when you put the device in. You wouldn't expect it necessarily to get better. So it's been stable up to 2 years in these patients, and this just shows it in another way, an RVCSS improvement. Now, interestingly, the FDA said that clinically meaningful benefit in these patients occurred when there was a more than 3-point improvement in the RVCSS, and in 25 of our patients in that 40 group, or 78%, sorry, in the 32 group that we have RVCSS, showed clinically meaningful benefit. And then this just shows it in bar form the percent of patients who had clinically meaningful benefit at each of the time points. And so you can see at 24 months now, almost 80% of patients have clinically relevant benefit, according to FDA standards. If you talk about the patients with the ulcers, 37 patients completed 12-month follow-up with ulcers. Of those 37 patients, 13 completely healed their ulcers, or 35%. Of those, 6 patients reached 24 months, and of those, all of those remained completely healed. Of the patients who were at 1 year that were not completely healed, 11 reached 24 months. 2 of them were completely healed. 2 of them had improved ulcer size. 4 of them, the ulcer size remained the same, and 3 had the ulcer size that was slightly worsened. You can see here, the ones that had the ulcer size that was the same or slightly worsened were more likely to have chronic ulcers for more than a year's duration prior to the placement of the Venovalve. At 24 months, 47% of patients' ulcers were completely healed, irrespective of previous status. Looking at pain score, again, you see an improvement initially at 3 months, and that's been stable for up to 24 months. And then likewise, quality of life scores improved and then remained relatively stable. The EQ-5D is kind of an overall quality of life, while the veins is more of a vein-specific quality of life. And there's just the veins symptom score, which is the symptoms related to venous disease. So in conclusion, the SAVI trial has demonstrated efficacy and safety of this device in the treatment of CVI and its sequelae. Device patency remains excellent. Early 2-year results indicate continued improvement of the average RVCSS, the veins quality of life, and the EQ-5D scores. Patients with ulcers continue to heal their ulcerations, although there is a subset of patients that have persistent ulcers. Further study is necessary to determine long-term outcomes in this complex patient population. I'd be happy to take any questions.
Hey, Matt, Joe Ronnie, East Carolina. And I apologize, I may have missed the meeting, but these patients all had their superficial reflux previously treated, as well as looked for perforators and...
Yeah, I didn't include the inclusion-exclusion criteria, but all these people had to have venograms done prior to being enrolled in the trial. They had to have their superficial venous reflux treated. They couldn't have any outflow issues, and so if they had an iliac occlusion, they had to be stented. They could be enrolled after having the stenting done. They had to wait 3 months, and there were a lot of people that had the greater saphenous vein ablation done prior. Perforators? Perforators, I don't think there's any specific criteria necessarily for perforators, but GSV reflex had to be ablated.
I know it's a small subset of patients, but in the 3 that the ulcer got worse, and then in the few that were stagnant, were those Venovalves all patent, or did they have any like occlusions, recanalization complications?
Yeah, that's a good question. I don't know if they were ones that recanalized after the fact. I can look into that and find that out for you, but they all had patent devices. It's really kind of intriguing to me because I had patients myself that thrombosed the device, and obviously not due to a technical issue. And then I opened it up with a penumbra just for the heck of it, why not? And then it subsequently occluded, and I thought, well, that device is a goner, this is it. And then it reopened. It's almost like, natural history of a DVT or whatever. And this patient had decreased reflux below the device because the valve was still functioning, and they were healing their ulcer. So it's really kind of intriguing to kind of watch these things play out.
Hey, Matt, thank you so much. I think we're all really excited for some new therapies in this area. One thing I guess I was a little disappointed in is the number of wound healing. And so I know there's not going to be data on such a small subset to hypothesize, but is there maybe a point of no return for some of these patients, meaning even if we restore a competent valve, there's not going to be, there's sort of a point at which you have to intervene early versus late? And the second question I have, just real quick, is was compression therapy also part of this? Meaning it's standard compression plus Venovalve, and just so we have a good sense of what it all involves as we try to figure out how to interpret the data? Thanks.
Yeah, I'll start with the second question, and that's an important question. We did keep track of compression therapy of the patients, and I didn't show it, but all these patients have continued maximal compression therapy, basically. So it hasn't been a worsening or improvement of compression. So they're using the same compression that they were using prior to the procedure. As far as your first question goes, I think there's a lot to be kind of figured out as we go forward. A lot of these people, maybe you need 2 devices. I don't know. All these people only received 1 device. Some of these people had another vein, and so maybe they need a device in both veins. So, overall, the number of patients that we've put Venovalves in is relatively low. So I think this is going to be figured out kind of as we become commercially available and enroll patients.
Last quick question.
Yeah, thanks, Jake Hemingway from Seattle. Can you talk a little bit about the actual improvement that patients saw in the veins, quality of life scores? Because the 10-point difference, for those of us that might not be as familiar with that specific quality of life score, might be a little bit hard to understand. Because if you look at the revised VCSS score, just healing the wound, which is a big improvement, obviously, is a 3-point difference, which would be a clinically meaningfully significant based on the FDA definition. Dropping the wound size a little bit. So there are a lot of different things that could contribute to that 3-point improvement. But in terms of the other quality of life, could you just speak about how meaningfully impactful those are?
That stuff like pain, swelling, clinically relevant issues that the patient experiences with venous insufficiency. And I think the vast majority of the patients showed improvement in that. I enrolled 6 or 7 patients in the study, and everybody comes back and it's like night and day. They love the change that they feel. These are people that have had ulcers for years and now they're healing their ulcers. And so I think it's a very promising device, and I look forward to kind of getting into real world usage once it becomes available. I think it's set to be hopefully this year sometime commercially available. So.
Just a fast comment. So I'm involved also in the trial, and just as Dr. Smeds mentioned, healing the ulcer is one thing, but those patients also experience a lot of other changes. There's a lot of improvement in their swelling and pain levels, and I think that's important also for the care of those patients. Thanks you, Matt, for the presentation.